All right, welcome back to the podcast. I am joined with Awais Aftab. He is a psychiatrist in practice in Cleveland, Ohio. He is into psychiatry and where sort of anti-psychiatry meets psychiatry. He is a practicing psychiatrist who runs an IOP partial program with about 40 patients. He publishes on the psychiatry and philosophy, and he has a very popular Substack. What is it called?
Psychiatry at the margins.
Psychiatry with Margins. I wanted to get that right. And he also is very popular on X, formerly known as Twitter, with about 23,000 followers. He often engages topics that are conflictual with nuance and articulation. And I am happy today to have him on to talk about the serotonin hypothesis and antidepressants. And we have, or he has pre-written, which I have commented on, a article that is 21 pages so right now, and it goes through all of the different articulations on this, the different theory, the conflicts in the theory, and what the main article, Moncrieff et al. 2022, which we'll be talking about, which was a meta-analysis and critical review, and then people that countered that. So I hope this is a discussion that's helpful for you. And so welcome to the podcast.
Thank you, David. Pleasure to be here.
So yeah, let's talk about the why this is an important conversation to have today. I feel like this, someone who is on X quite a bit, there's kind of this new push against antidepressants that we should get rid of them completely almost. And lots of anti-psychiatry folk often saying things like, this is there's no research behind this and such. So tell me from your perspective why this is an important topic to talk about today.
Yeah, so a number of forces have been developing and kind of converging over the years to create this situation where the antidepressants have come under immense scrutiny, and people have very strong and heated opinions about these issues. And part of this has to do with the fact that there has been a general sentiment that antidepressants are overprescribed, and it is the case that many adverse effects of antidepressants have historically been neglected or not as well recognized. So, in particular, issues with regards to antidepressant withdrawal, issues with regards to sexual dysfunction. So, given the large number of people who are on these medications, we have growing numbers of people who have had very negative, in some cases, life derailing negative experiences with these medications. And so there has been a growing sentiment that, these medications are dangerous in some ways, and that the profession has not been paying attention to that. Um, and there are other kind of academics, sometimes politicians, political commentators who have been cashing in on that resentment that has been building against antidepressants and to kind of generate more and more provocative claims. So this has happened in the scientific world where people have advanced scientific critiques against the chemical imbalance the so-called chemical imbalance hypothesis or the serotonin hypothesis. They have advanced critiques against the efficacy of medications, and they have generated debates around how antidepressants work, if they work at all. On the political side, there has been an emerging tendency, especially among right-wing commentators, to see antidepressants as a false solution to life problems, and people have been eager to blame antidepressants for things such as gun violence, school shooting, etc. So the end result is that a number of different people with their own different agendas have developed some solidarity around characterizing antidepressants as a threat.
Right. And so, okay, just real quick, do you have any conflicts of interest?
No, no,
Do you
no,
have
yeah,
any pharma companies that are paying you to come on this podcast?
no, yeah, no.
Okay. Have you ever received any pharmaceutical money?
I have not.
Okay.
Yeah.
Okay, me neither. I have no conflicts of interest either. So we're
Yeah.
going into this as intellectuals, and I've even heard online like, was your residency paid for by pharmaceutical companies? Did they create the curriculum of your residency at all? Do you know?
And there was no influence at all during my residency training.
Me neither.
Yeah,
There was no drug companies paying for meals for us and
yeah,
stuff like that. Okay. So I think that's really important to get out of the way there.
yeah,
And then the other thing is I've covered mass shooting. I've had two experts on. I even published on my website every single mass shooter, what medications they were on. There's they were on all sorts of different medications, and not all of them were on medications. And there's no
yeah.
link. There's no like one type of medication that they were on. Some of them were on months before, some of them not on at all. Some of them were prescribed, never take. But yeah, there is this interesting thing with mass shooting and medications that like, oh, it's because of the medications. But and I when I first heard this, I was like, oh no. Like I was really
Mm.
scared. I was like, I don't want to give something that contributes to that. So I really looked at this um and didn't find anything. Anything you want to comment on that before we jump into the bigger.
No, I agree. I think, anyone who has looked at this issue with an open mind and, some kind of neutral objective perspective has come away with the conclusion that there is no solid or reliable link between antidepressant use and any of these kind of instances of school shooting or gun violence that we have been seeing.
So we're going to zoom in on serotonin today, the serotonin hypothesis. So break this down. What is the serotonin hypothesis?
So people have, talked about a serotonin hypothesis, or in some cases, a serotonin theory, but in the literature, there's actually no precise or single articulation of what that is. So when we talk about serotonin hypothesis, we're talking about a vague cluster of ideas that are linked together, in which serotonin plays some kind of a role, either in the etiology of depression or in the manner in which how antidepressants work. This all got enmeshed in the late 90s through the pharmaceutical industry advertising trope of chemical imbalance that then became a more widely known cultural idea as well. And even many physicians started using that language in their communication with patients. The most concrete understanding that some people had of that idea was that depression is caused by a deficiency of serotonin, that there are lower levels of serotonin in the brain or in synapses, and antidepressant medications correct that deficiency by boosting the levels of serotonin. So when a lot of people hear serotonin hypothesis, serotonin theory, that's the idea they think of immediately. But that kind of idea was recognized even in the 90s as most likely false because research had not really supported that. In fact, researchers were considering other aspects of serotonin functioning. They were looking at for example, receptor distribution, receptor sensitivity within the serotonin system. They were looking at how how different people are susceptible to things like tryptophan depletion, and whether this is something that predicts the onset of depression, or whether this is something that is more of a general risk factor. And so they were trying to examine what kind of alterations can exist in the serotonin system in the depressed, individuals, while at the same time recognizing that depression is not one thing, that depression is a heterogeneous cluster, it's a heterogeneous syndrome. Different people, become depressed with different pathways. And the idea was that some of these pathways perhaps involve alterations of serotonin. So people were studying that using different scientific methodologies. So there were PET receptor studies, there were tryptophan depletion studies. Um, the overall quality of that literature is somewhat weak, characteristic of the scientific research of late 90s, early 2000s, smaller samples, other methodological issues, but they do relatively consistently point towards some kind of serotonin alteration existing in some people. Then there's the a broader kind of hypothesis under the umbrella of serotonin theory, which is that there may not be an alteration or abnormality of serotonin itself in depression, but serotonin pathways are generally involved in the regulation of mood and behavior. And because serotonin as a pathway is involved, it provides a target for us to intervene on. So most of the kind of antidepressant, second generation antidepressants that were developed in 90s, 2000s are serotonin based or other monoaminic based. So this broader hypothesis recognizes that they may not be correcting a deficiency. There may not be a serotonin deficiency, but they're still acting on those serotonin pathways, and through acting on those serotonin pathways, they're producing desirable therapeutic effects. So when we have to keep these different types of hypotheses in mind and the range of them. So when people like Professor Moncrieff and others say that serotonin hypothesis doesn't have enough support or is being rejected, or when people say that chemical imbalance hypotheses have been rejected, they have to be clear about what it is that has been disproven, what it is that, for which there is varying degrees of scientific support, and what are still the open scientific questions in this area.
Yeah, when I think about this, I think about, you know, it's there's a broader question of, is depression a neurological thing? Like, are there neurological things going on in the brain when someone's depressed, right?
Yes.
And one of the most convincing things that I've looked at when I've looked at this is, the depression rates in people with brain diseases is actually a lot higher than in a normal brain, a healthy person. For
Mhm.
example, frontal temporal dementia, depression rate is 40%. Someone with cerebral basal degeneration, 73% of them have depression. Suicide rates in Huntington's disease is quite a
Mhm.
bit higher. Um, there's 50% rate of depression in people with Parkinson's disease,
Mhm.
which, have issues with dopamine. So, and the list goes on. Lewy body disease, higher
Mhm.
rates, people with strokes, higher rates. So there is stuff going on in the brain. The question is, like, what is that stuff, right?
Yes, yeah. The mind-body relationship is, it's a complex scientific and philosophical issue. Um, but I think these cases where depression is clearly a result of medical general medical disorders or neurological disorders, to my mind, that provides clear evidence that there are pathways that are involved in regulation of mood and behavior, and sometimes these pathways can be disrupted by pathological processes. So you mentioned a lot of these clear examples. Autoimmune disorders are another one. Very high rates of depression in people with autoimmune conditions. In treatment of hepatitis, for example, interferon treatment recognized as producing high rates of depression, and hypothyroidism is a very well recognized. And in subsets of people with melancholic depression, we recognize that there is HPA axis dysregulation going on in the
Mhm.
in the regulation of cortisol. So we recognize that these cases happen. Now, an average person with depression as a clinical problem is probably not going to have an abnormality of thyroid or abnormality of autoimmune processes, but as generally, when we look at depression as a syndrome, we can see that all of these biological pathways are involved.
Yeah. And then there's another group of people who think, like, oh, it's just trauma, right?
Yeah.
Any mental health issue is just trauma. And when I did a huge deep dive on adverse childhood experiences, their lasting impact. And, we know that if you have the more adverse childhood experiences you have, the higher the risk of pretty much every mental health issue, and every physical issue as
Mhm.
well, right? So it of course it impacts, like, even things like cancer. It doubles the
Mhm.
rate of cancer. It doubles the rate of skeletal fractures, right?
Mhm.
So, but it's not one equals one, right?
Yeah.
So it just increases the risk. It doesn't necessarily doom someone to a specific issue.
I agree with you. Yeah, I mean the association between childhood adverse experiences and not just depression but other mental health problems is pretty strong and robust. But even there, the effect sizes usually tend to range from zero point 0.3 to zero point 0.4, kind of in this medium-ish range. And the most consistent evidence tends to point not towards the adverse experiences themselves, but rather the perception of those experiences. So, for example, in prospective studies where they follow people who have had them, the association is weaker versus in retrospective studies where the kind of the report of these adverse experiences is based on the person's recall and their perception of it, the association is more stronger. So there's that aspect too. But it remains the case that, adverse childhood experiences are some of the most, important and well recognized, well replicated risk factors. But that's not the whole story. In fact, and probably some of the biggest risk factors that have been identified are temperamental ones, with neuroticism showing up in most studies as a pretty robust and reliable factor. So at the very least, we're looking at this interaction between neuroticism and other aspects of temperament with childhood experiences in combination with acute stressors and in combination with other biological risk factors, including genetics, but including immune factors and other relevant things.
Okay, before we get into the Moncrieff et al. Study, um, let's go through a couple of these studies on like Salvan et al. 2023, which basically shows that serotonin helps control impulses and also affects how we feel about rewards and our mood. Explain to me this study and why you think this is important.
Yeah, so this study generally highlights it. It provides a good illustration of how serotonin system is generally involved in the regulation of mood and behavior. So research into behavioral effects of serotonin has been going on for decades, and sometimes there are kind of conflicting findings in the neuroscience literature, and people have been figuring out ways how to integrate kind of how this makes sense. So Salvin et al. 2023 paper is one of them in which they use both kind of animal data as well as human data to map out the functional connectivity of the serotonin receptor symptom and trying to see what corresponds to what. And basically, they find two different clusters of functional connectivity that are targeting two different types of problems or two different types of experiences. One aspect of serotonin functioning seems to be based on issues around impulsivity and aggression, versus the other aspect of serotonin functioning seems to relate to kind of emotional processing. In particular, how kind of negative bias shows up in various kinds of information processing and reward processing. So serotonin seems to one inhibit impulsivity and inhibit aggression, and on the other side, it seems to shift emotional information processing into a less negative and more positive direction. So Salvin et al. Kind of show that mapping based on functional connection, but then a later study by Colvett et al. In 2024, they actually carry out this really elegant experiment in which they directly increase the level of serotonin in the synapses without using SSRI. So they use an alternative strategy of increasing serotonin levels, and similarly, they essentially find out the same kind of effect, that serotonin enhances behavioral inhibition and that it reduces sensitivity for outcomes in aversive context, basically, showing its effects on emotional processing. So these, I think, and these are just some of the more recent, well-designed, rigorous studies. There are so many others, and to my mind, the literature is very robust on this. That serotonin is involved in behavior, it's involved in regulation of impulsivity and aggression, but also regulation of emotional information processing.
Yeah, that's good. So low serotonin, being impatient or acting without thinking, um, or seeing rewards as less valuable. Is that a good summary of the first one?
Yes, yeah, and so so people who have reduced serotonergic transmission, they tend to be more impulsive and tend to act out in an impulsive manner, aggressive manner, and they tend to interpret neutral stimuli, for example, in a negative, emotionally negative manner.
Yeah, and I was thinking to myself, okay, what are all the animal studies that have shown natural things to increase serotonin? And I found things like exercise increase serotonin, and there's a lot of other things, right, too. So it's not just it's like it's in there for a reason. We have serotonin in our brain for a reason, right? And we're just trying to like figure this out. So these are good studies from 2023, 2024, um, coming after the Moncrieff et al., which was in 2022.
Yeah, and there's a very rich biological history to the evolution of serotonin itself. Evolutionary biologists have been interested in the role serotonin has played, in kind of behavior of biological organisms. So the interesting thing is that Moncrieff has publicly kind of made the claims that, oh, this whole kind of scientific literature on serotonin behavior is essentially junk and it's worthless, and the only thing we can confidently say is that serotonin inhibits sexuality. And this is something she wrote herself and can comment. And it's hilarious to me. I get that, that someone can say that given the wealth of scientific literature we have on this topic.
So let's dive into this specifically. Let's talk about what it did say, and then we're going to go through some of the main critiques of this article. So this is a 2022 umbrella review that focused on serotonin association, not antidepressant efficacy. So it was really just looking at like, is serotonin associated with different genetic things? Is it associated with different mood issues? So take me through the study and what
Yeah.
it showed.
So the first thing to recognize that this is an umbrella review, or what you can call kind of a big picture overview of the literature. It is not a systematic review. So they did not kind of set out systematic criteria of kind of conducting a literature survey and identifying studies. So it is not a systematic review, and it is also not a meta-analysis. It does not take in data from individual studies and pools it together. Essentially, it is a somewhat a narrative style review of larger meta-analysis systematic reviews and large genetic data set studies that have been done looking at various associations between serotonin and depression. So it outlines what those other systematic reviews meta-analysis have found, and then presents a kind of critical evaluation of those. And I think the main thing it highlights is that there's no evidence of serotonin deficiency or kind of reduce low serotonin in depression, which everyone even in the 90s was kind of agreeing that, yeah, there's no direct evidence of that. But then it kind of says that it says that there's also kind of no good evidence that serotonin abnormalities of any sort are have been associated with depression. Um, and then in the discussion, even though the review itself is only looking at association between serotonin abnormalities and depressive diagnosis, it kind of implies that it generalizes into saying that there's no relationship between serotonin and depression at all, and that it cannot be inferred that antidepressants are working through the serotonin system. So even though they did not directly look at any of the literature around antidepressant mechanisms or antidepressant efficacy. So these claims generated a pretty fierce response from the academic and scientific community.
Right. Let me pause there and emphasize something. The author extended that antidepressants do not have a benefit and just cause a general blunting rather than an action, on serotonin, right? So it's like it's changing what from like this is association studies on
Yeah.
serotonin to antidepressants, which she doesn't really go into antidepressant trials, right?
Yes, she doesn't. Yeah, it is not. But she kind of she cashes in on the popular misunderstanding. So what is a layperson's idea of what an antidepressant is doing? It is that, oh, there's a chemical imbalance and the antidepressants are fixing or correcting that chemical imbalance. So Moncrieff essentially just kind of uses that, same structure of argument, and she says, well, if there is no chemical imbalance, then there is nothing to fix. Therefore, it's questionable that antidepressants are effective, or that they have any kind of specific serotonin related effects. I mean, it's a clearly fallacious argument. It's
Right.
it's logically
Right.
invalid and scientifically
And
invalid, but that's
you know,
what she uses.
yeah. And I've been doing this podcast for like 7 years, and I would challenge any of my listeners to go back and find one time that
Yeah,
anyone said this fallacious claim that so
yeah,
she's kind of that depression is from low serotonin in the brain. But this is how people think, right? This is
yeah,
this is a very simplistic way, and I've heard patients
hmm
say, well,
yeah,
I need this because I have low serotonin in my brain. Um, but this is not something I learned in residency.
yeah.
Uh, it's something that I learned that was a simple way that some people understand very complex things.
Yeah, I agree with that. And I think because there's this disconnect between the academic understanding and the general understanding, this article, when it was published, became a viral sensation overnight because the media covered it as saying that, the chemical imbalance hypothesis have been proven to be wrong, and and they focused on the antidepressant angle, saying that antidepressants don't fix any chemical imbalance. And so, I mean, I think in retrospect, it is very clear that the publication of that article was used as a launching pad for a very effective media campaign against antidepressant use, and also to challenge the general idea that depression is a medical problem or a medical disorder.
Right. Which which I come back to, well, lots of brain diseases have much higher rates of depression. I think to myself every time I see someone anti-psychiatry, I'm like, let open up a door that I could send you some catatonic patients and you will soon believe in the power of good treatment. Like you
Yeah.
cannot heal someone who's catatonic with your pseudoscience. Right.
Yeah, and I mean, and I think there's there's an inadequate recognition of depression as a heterogeneous spectrum. Some people on the milder end, their depression is an exaggerated version of life difficulties, life distress, or situational distress. But then there are other patients with depression who have severe psychomotor retardation and severe anhedonia, and other kinds of severe sleep issues, and we see these in studies as well. We see cortisol dysregulation, we see REM sleep abnormalities. We see kind of genetic associations, kind of in certain cases. I think anyone who just tries to paint depression with a broad brush, anyone who says that, oh, this all of depression is a normal, understandable reaction, or all of depression is an organic style disorder like Parkinson's. I think it would
Right.
be inadequate because
Yeah.
things are very different.
Yeah. And I'm not saying that either because
Yeah,
I think there are many pathways there.
yeah,
Um, and there are people with family histories, like, multiple people have committed suicide. Those people may need a different treatment,
yeah,
than someone without a family history. Is someone who's high in neuroticism.
yeah,
They may need a different treatment than someone who's lower in neuroticism.
hmm
Um, yeah, so it's like depression is kind of like to me like a fever almost. I don't know.
hmm
It's like this is the final common pathway of a lot of different things, right?
yeah,
And so I'm someone who advocates for psychotherapy, for exercise, for diet changes, and when I see a patient, I'll sometimes get an email like, hey, why do you think I have depression, blah blah blah. And I'm like, well, I don't know if I can tell you over just
yeah,
an email because it takes me sometimes 50 minutes to come
hmm
to a conclusion on what's going to be the biggest win for someone.
yeah,
And there's a lot of different things that, I may ask questions, and based on how you answer that question, I
hmm
may go in a completely different direction in question asking.
yeah,
And that's something that I've developed over, 11 years of seeing patients as an attending is when I hear a couple things, then I will ask a couple other things. But I won't know to ask those couple other things until I hear some of the story, you know?
Yeah.
You know what I mean?
Yeah, I know. I agree. Yeah, I mean, I think depression is just it's a descriptive characterization, and people end up in a depressed state for very different reasons with a wide variety of combinations of risk factors and a wide variety of combination of precipitating factors. So it's the it's a good clinical conceptualization or a good case formulation that drives the treatment and kind of sorts the person into the appropriate treatment strategies. So there's no one size fits all, and that's one of the reasons I think because depression is such a heterogeneous cluster. Treatments in general, if you pool their effects as averages, the effects are generally weak, but or modest, you can say, whether this is antidepressants or psychotherapy or exercise. This is because different people are responding to things in different ways. And for all of them, I think some people respond robustly to psychotherapy, and you get wonderful clinical response. Some people respond robustly to exercise. Some people respond robustly to antidepressants, and then there are others who just kind of who get better, but not enough. And in many of those cases, you end up using multiple treatment strategies in coordination because no one strategy is going to be sufficient to take care of those problems.
Yeah, absolutely. A new one I like is creatine, five
Hmm.
grams a day. There's some new study. I've been looking at those studies for years, hesitant to talk about it, but now
Yeah.
some of the newer studies are coming out. I'm like, oh, I can talk about this publicly, you know. And so there's some
Yeah.
things like that where I'm like, yeah, I'm hesitant to talk about this because the data
Hmm.
is so early, and I know people listen and people take it for what it is. But there was a
Hmm.
new study we're going to talk about. I'm going to do a deep dive on creatine in a couple months, and we're going to go through. There was a new one on CBT with creatine versus placebo, and there was like
Hmm.
a 6 point difference in the
Wow.
creatine group versus the placebo group for the, and I was like, wow, that's amazing. So and why creatine? There's a metabolic impact, just like
Hmm.
maybe an improvement of the mitochondria. We'll go through the mechanism. It's very detailed, but yeah,
Yeah, no, I mean right now metabolic psychiatry and lifestyle psychiatry is having a kind of a booming moment, and we're seeing a lot of attention being devoted and diverted to addressing metabolic aspects of depression. And I'm excited to see as well where this leads and what kind of scientific evidence emerges from this.
yeah. Okay, let's go. Is there anything from the study we want to highlight as like this is what the study actually found? Like, is there anything from
I think
Moncrieff et
the
al.
main thing to
Study?
highlight, I think, the central conclusion that, one, that there is no serotonin deficiency, established serotonin deficiency in depression, widely recognized. I think, that I think, makes sense. I think, and then I think that there are some of the other implications that we talked about, but we can, maybe perhaps transition into the reactions
Yes.
to the Moncrieff paper.
Yeah.
Yeah, so since the original paper was published in Molecular Psychiatry, over a period of a year after its publication, it published a series of commentaries and critical responses to the Moncrieff paper, and included some very distinguished names. In fact, the leading kind of critical response was by Samir Johar and colleagues, and it was kind of 35 people, and it was kind of a who's who of people involved in mood disorders research. And it was titled "A Leaky Umbrella Has Little Value. Evidence Clearly Indicates the Serotonin System is Implicated in Depression." And they went through kind of a number of different methodological issues with their approach, as well as kind of highlighting things that they had ignored or minimized. So one, as I mentioned, they chose to essentially just eyeball the results of these other systematic reviews and meta-analysis rather than trying to take the data and do a meta-analysis of their own, which would have been the more productive thing to do, especially with things like kind of tryptophan depletion studies or things like PET imaging studies. So that's one kind of methodological issue that they brought up. And then their approach towards bringing up the use of antidepressants as a confounding factor was pretty inconsistent too. If the results were such that they implicated the serotonin system in some way, the Moncrieff and colleagues had a tendency to say, oh, this could have been due to antidepressant use. But if the results were kind of in accordance with what they were expecting, they wouldn't bring that up. Now, two major, I think, scientific kind of results
Wait,
that they neglected or minimized. Yeah.
let me ask you a question on that. So what did Moncrieff et al. Do in terms of people on psychiatric medications versus not on psychiatric medications?
So they themselves did not conduct any specific analysis of people on or off. They just essentially, like I mentioned, they were relying on the results already reported. So, for example, for tryptophan depletion studies or PET imaging studies, if the results indicated an association, they'll simply bring it up as a point that, oh, these people might have been on antidepressants, or the people, some of them were antidepressants, so perhaps the results are explained by these people being on antidepressants rather than not. So they essentially brought it up as an objection, but they didn't conduct any analysis of their own in this regard.
Okay.
Yeah. So I think the two areas where existing research seems to be the suggestive of serotonin alteration in some manner are the tryptophan depletion studies and kind of serotonin receptor PET imaging studies. So in the tryptophan depletion studies, what they had done was that they had taken individuals kind of both with history of depression, both kind of healthy individuals, but who may have had family history of depression, and they kind of artificially depleted the levels of tryptophan in their body, and then they see, did something happen to their depression? Did their mood worsen? And the previous meta-analysis that had been done on that, it had in fact shown that in people with a family history of depression and in people who have been diagnosed with depression, tryptophan depletion worsens their mood. And so that finding that had been established before, Moncrieff et al. Essentially just minimized that and did not give it due consideration. And the second thing was that in PET studies that had been done of examining at serotonin receptor binding, they had simply kind of dismissed those results as saying that different studies had done had reported different results or inconsistent results. But the critical responses pointed out that if in fact they had done a meta-analytic kind of approach, they would have seen that some areas show up consistently as implicated. And in particular, serotonin receptor binding in midbrain and amygdala seems to be consistently lower in these previous studies. But again, that was not properly kind of recognized or acknowledged by the Moncrieff et al. Paper. And another thing was that after the Moncrieff paper came out, there was a small study published, which was the first direct assessment of serotonin release capacity. So all of the existing, scientific studies so far, they had relied on indirect assessments of serotonin because we didn't have the methodological tools to kind of directly assess serotonin release capacity. So this was the first one that actually developed the methodology to measure that. And what they found was that in a small sample of people who were experiencing major depressive episode, and these were not on antidepressant medications, they found that people with depression had lower serotonin release capacity compared to healthy controls. Now this is a small study. The sample size was not that large, and the statistical significance was just kind of bordering on significance. So the general understanding has been that this is at best a preliminary demonstration and not a conclusive result. But it shows again that this is an area of open scientific inquiry, and that the available evidence that we have suggests or points towards some kind of serotonin alteration in some people, but whether this is conclusively demonstrated, kind of remains to be seen.
So this was Eratos et al.
Yes.
Called
Yeah.
Brain Serotonin Release is Reduced in Patients with Depression, A11C Symbi 36 positron emission tomography study with a D-amphetamine challenge. Um, and so it did find that there were people with depression, their brains reacted differently. And part of when I look at these types of brain studies and there's a certain percentage different reactivity, it's like very hard for me to understand what that means in terms of like, does that decrease reactivity? Um, is it clinically significant? Right. And with a small number change, it could be really significant. Right. And
Yeah.
it's hard for us to know, but there is a change. But it's like, is it when it's clinically significant? It's
Yeah.
like, okay, does that mean we could test depressed people? And if they're low in this, then they're reliably, yes, that person is depressed, right? Or if you took 1,000 people and you tested it, could you pick out from that 1,000 people how many of them are depressed based on it being lower?
Yeah, it's difficult to kind of extrapolate the clinical utility of these kinds of things. So what happened in the study was that there was a shift in the distribution of the serotonin release capacity, but the distribution is still very overlapping. So so for when you look at the distribution of serotonin release capacity, like a lot of other variables, you get a range. So there's a range in the healthy controls, and there's a range in individuals with major depressive episode. And the range, if you look at that, is shifted in a kind of a reduced kind of capacity direction. So that there's an average difference between those ranges, but there's also a big deal of overlap. And so that makes the clinical application of tests like that very challenging. That if there's broad overlap in the distributions, then the sensitivity and specificity of that kind of measure for the purposes of clinical diagnosis or treatment gets reduced. But I think right now it's really kind of premature to even say what kind of clinical application this could have, because that's just the first study that has come out, and hopefully with larger studies they can examine some kind of predictive value for clinical treatment too.
Okay. So, in summary, uh, Johar and colleagues say to summarize, the methodology is inconsistent with an umbrella review and substantial bias created by the author's chosen quality criteria, selective reporting, and interpretation of results. There is an underappreciation of the complexities of neuroscience and neuropsychopharmacology, and therefore impossible for the reader to draw a valid and reliable conclusion. A more accurate and constructive conclusion would be that acute tryptophan depletion and decreased plasma tryptophan in depressed indicate a role for 5-HT in those vulnerable to or suffering from depression, and that molecular imaging suggests the system is perturbed. The proven efficacy of SSRIs in a proportion of people with depression lends credibility to this position. Yeah.
Yes, yeah. I think it's pretty well stated. I think I do want to emphasize that the literature, the available scientific evidence is suggestive of some serotonin alteration in a subset of people, but it is still not like very high quality, super conclusive evidence. So I do think we have to keep in mind that scientific evidence comes in degrees, and we're still looking at scientific evidence that is in the low to moderate range. But again, that point, recognizing that does not mean that we say that, oh, we can confidently say that no one with depression has any serotonin alterations or abnormalities.
Mm-hmm. Yeah. And I think the other thing I think about is like, how do you like parse out the different types of depression? Like, and then study those individually. Because I imagine they would have different types of things going on. Someone with
Yeah,
borderline personality disorder
yeah.
who we know, you know, is not going to respond to antidepressants,
Mhm.
right? We know that the APA just came out with a stance on like
Yeah.
for BPD symptoms, medications really aren't the answer.
Yeah, I mean there's a huge and I think that people have been trying for decades to try to come up with some kind of adequate subtyping of depression that would guide a treatment in a meaningful way, and it has been challenging because a lot of the usual kind of descriptive categorizations that we have had in the past, for example, atypical depression or neurotic depression, anxious distress, etc. They don't seem to reliably predict response to, for example, antidepressant treatment, psychotherapy, things like that. The only thing that really stands out somewhat the test of time is melancholic depression. That
Mhm.
melancholic depression consistently kind of shows higher kind of percentage of cases that have HPA axis, dysregulation, and they show a poor response to SSRIs and standard antidepressants, and a comparatively better response to tricyclics as well as things like ECT. So with melancholic depression, we have some evidence that there's something different going on with that, and then based on comorbidities, we can make some reasonable inferences as well. So as you mentioned, the comorbidity with borderline personality disorder is one of the ones that has been repeatedly shown in literature to have poorer outcomes in the treatment of depression.
Mhm.
And which shows that, until we address that underlying psychodynamics and underlying self and interpersonal dynamics of borderline in some way, the person would remain susceptible to, their emotional difficulties.
Right. So, melancholic depression, um, define that just so that we're all on the same page here.
Yeah, so and different people would come up with slightly different operationalization of that, but essentially, melancholic depression is the depression that is characterized by very prominent anhedonia, severe psychomotor retardation, often an existential quality of despair and distress, early morning awakening, and usually tends to show REM sleep abnormalities. And in general, it is not that strongly associated with acute life stressors. So it tends to come and go with a weaker link between with life stressors, and it tends to have a more kind of independent biological flavor to it.
So, huge anhedonia, huge loss of pleasure, right?
Yeah.
Depression worse in the morning. There's early morning awakenings, at least
Hmm.
2 hours earlier than
Yeah.
usual. Marked psychomotor agitation or retardation. So slowed or restless, you know. Sometimes there's weight loss,
Mhm.
uh, anorexia, excessive guilt. So usually about three of those at least for the
Yeah. And this was
depression.
melancholic depression was the one that was kind of classically recognized as being, depression prior to our modern era of DSM-3. If you look at, what cases were being diagnosed as depressed in the first half of the 20th century, or who were being admitted to psychiatric hospitals as depression, then they were by and large people with melancholic depression and psychotic depression.
And my experience of working in a psychiatric hospital, these patients do not get better in 3 days.
Yeah.
Someone with
Yeah.
BPD, borderline personality disorder, could come in, get put on some meds. 3 days later, they're completely back to normal. It's like they've completely flipped out of it.
Mhm.
Someone with melancholic depression 3 days later looks exactly the same.
Yeah.
Very little
Yeah.
change.
Yeah, it tends to be kind of more the course of improvement tends to be slower. It takes weeks, often, sometimes even longer for these people. And so in other cases, we see this rapid, emotional reactivity where people, especially kind of, with borderline personality dynamics, they can be very sensitive to, whatever is going on in their life. They can be very sensitive to rejection, abandonment that precipitates an acute depressive crisis, and then it very quickly resolves. Versus that is not the situation in melancholic depression at all. It is severe, more kind of persistent, more protracted, and it takes time for these people to get better.
Okay, let's jump back into the critique of the study. Let's talk about this Bartova et colleagues 2023 critique. Anything you want to mention on this?
Yeah, I think a lot of it mimics the similar kind of points that Johar and colleagues had made, but I think it's worth emphasizing, their assessment of the study too, just to consolidate that this wasn't just one group of scientists. So Bartow and colleagues, they say since Moncrieff et al.'s deduction is based on selected literature covering serotonin exclusively, and hence addressing only a part of the complex understanding of depression, we argue that the author's conclusion that the serotonin theory cannot be empirically substantiated cannot be derived from the present work. A meta-analysis revealing spatial temporal dynamics of the serotonergic neurotransmission in depression underlines the fact that serotonin represents a crucial but dynamic neurobiological underpinning of depression. And the meta-analysis that they're citing is one from 2014 of molecular imaging of serotonin transporters in major depression, which revealed reduction in serotonin transporters in midbrain and amygdala, which is also consistent with some of the other kind of PET imaging work that has been done. So again, kind of highlighting that, Moncrieff et al. Looked at, a few selected reviews and meta-analysis, and then they extrapolated, their own assessment to the entire literature, and people more familiar with that literature pointed out, things that they have missed or neglected or misinterpreted.
Great. So what I'm getting from this is that in the midbrain, in the amygdala, there are a reduction in serotonin transporters, and this is likely to be the spatial temporal dynamics, meaning like as the depression progresses from not treated yet to treated, we may see this change over time. Is that is that how you're reading this?
Yeah, yes, I think that they're referring to that as well.
Um,
And I think this probably provides a kind of, I think, useful transition into what we currently know about how antidepressant works. So, if I guess the question is that if antidepressants are not correcting a serotonin deficiency, then what are they doing? And that has been a focus of some of my kind of public writing as well, because I think the actual scientific literature is, very very interesting and very very informative. And what we see is that we have several lines of research in this area, and they focus on a few different things. There's one that focuses on shifts in emotional information processing that kind of monoaminergic medicines that work through serotonin and other systems, they produce shifts in emotional processing, either in making it less negative or kind of making it more positive in response. And this directly ties in with some of the serotonin research that we showed. We for example, like, we saw that um, uh, serotonin system is implicated, not just in behavioral control and impulse control, but also in emotional processing. So this hypothesis bases on that fact that serotonin SSRIs are boosting serotonin, and by doing so, they shift the emotional processing in a more positive direction. And there's some preliminary evidence showing that SSRIs seem to primarily affect the processing of negative emotions, versus norepinephrine reuptake inhibitors kind of affect how participants respond to positive or rewarding stimuli. So there are some differences there, preliminary basis, and this is an effect that starts showing up very rapidly when we give people SSRIs. So sometimes even after one dose, but often after a few doses, on these cognitive tests, where if you ask people, for example, to rate neutral faces, previously depressed people would rate them as being more sad or showing negative emotions. And now, if they're on SSRIs, they would rate those same neutral faces as either showing positive emotions or showing less negative emotions. So these are kind of, operational cognitive tasks that the researchers are using to measure emotional processing. So they start showing these changes pretty rapidly after starting an antidepressant. And then the researchers hypothesize that this shift in emotional processing interacts with the environment. So if the person is in an environment in which they can relearn negative association. And if they can start to interact with other people, in a more positive manner, thanks to those emotional shifts, that sort of like shows up as progressive improvement in
Mm.
depression over the course of several weeks. So it's a interaction between shift in emotional processing interacting with a positive social environment, which also kind of fits in with the literature we have that SSRIs work better when there's a more therapeutic environment around the people, and then if people kind of are in harsh environments, adverse environments, antidepressant kind of efficacy, correspondingly goes down. And to my mind, it also highlights the value of combining antidepressants with psychotherapy too, because
Mm.
psychotherapy provides that opportunity to relearn those associations. A kind of complementary aspect of this is the hypothesis around cognitive flexibility and neuroplasticity. So there's a whole line of research showing that antidepressants, including serotonergic antidepressants, they increase the levels of brain-derived neurotrophic factor, and they activate a receptor TRKB, which enhances synapse formation and maintenance. Now, there's still kind of ongoing discussion of, is this process, independent of serotonin, or is there some kind of, link with serotonin happening? And that's still up for debate. I think there's a general sentiment that many people think that serotonin is going to be involved in some way, versus there's a group of researchers that think that this is entirely independent. But regardless, it provides another method of action that boosts those changes in emotional processing that we see. Because the psychological manifestation of neuroplasticity is cognitive flexibility, the person being able to modify and kind of change their unhelpful patterns in which they are stuck. So that's another kind of pathway through which it is hypothesized that antidepressants improve thing.
Yeah.
And the
So
third one,
wait,
yeah, sorry.
before we get to the third one, so the first one's interesting to me because, okay, so you have facial, neutral facial expressions,
Yeah.
and you'll have people who are depressed. They have this negative filter that they put on, and they're imagining these neutral faces to be more critical or more angry or more sad, right? This is like micro expression, essentially, like
Hmm.
small moments of facial expressions and how they're reading it and how they're interpreting it. And the thing that comes to my mind is I had a patient just the other day who, like, I empathized with as I normally would, and he said, "I feel like you're being sarcastic," and it's like a paranoid
Hmm.
transference, right? He's
Yeah.
he's projecting onto me that I am being critical towards him, that I'm making fun of him, and of course I wasn't. I'm not making
Yeah.
fun of him in my brain. That's not my experience.
Yeah.
But imagine going through the world, imagining that everyone's kind of making fun of you or critical towards you. Um, and then you get the right medication, and maybe that shifts, or therapy, right? So
Yeah.
therapy can
Yeah.
also help with this over time. And then subsequently, you're in many interactions with people where you're having more, you're thinking the best of them,
Hmm.
which leads to more affiliative attachments, right?
Yeah.
And then your second thing about the BDNF, this is something I've covered. Of course, SSRIs aren't the only thing that increases
Hmm.
BDNF. Um, Ketamine has been shown to, um, exercise,
Hmm.
diet, even. So there's a bunch of different types of things that have been shown to increase BDNF that lead to less depression. So this is another good mechanism for SSRIs as well. ECT increases BDNF quite a
Yep.
bit. Okay, so the third one's neuroticism. Go
Yes.
ahead.
Yeah, if you look at the general kind of scientific literature on antidepressant mechanism, this one doesn't usually get as much, doesn't get highlighted as much, but there's a very well respected tradition of, examining this as a pathway. And in fact, we have a very beautifully done kind of placebo-controlled randomized trial from 2009 that investigated this issue. So they took people with kind of, who were experiencing major depression, and they treated them with an SSRI paroxetine or placebo or cognitive therapy, and then they kind of examine their outcomes in relationship to personality traits. And in particular, they were looking at neuroticism and extroversion. So neuroticism, it's one of those kind of big five personality dimensions, and it refers to this general pattern towards negative emotions, a heightened sensitivity to stress, and kind of negative emotional processing. So it's one of the more kind of it's one of the personality traits that's closely linked to vulnerability to depression and anxiety. And so in this particular trial, what they found was that people who took paroxetine, they experienced significantly greater changes in neuroticism and extroversion compared to those who took placebo. And that even when you statistically took into account the improvement in depression, the association with neuroticism changes was still significant. So patients taking paroxetine showed nearly 7 times greater reductions in neuroticism and almost kind of 4 times greater improvement in extroversion compared to those who had in placebo. And these degrees of kind of this degree of reduction in neuroticism was also a predictor of these people kind of staying well and not having a lower relapse rate going forward. Now in kind of in placebo patients, people who responded to placebo, their depressive symptoms went down, but their neuroticism scores and extroversion scores did not change, kind of highlighting that there was this kind of a more specific action of antidepressants on neuroticism and extroversion that was not being seen in placebo-related antidepressant improvement. And so I think that, and again, there's rich literature on associations between neuroticism and the serotonergic system as well, and that part of the expression of neuroticism may be kind of based on how the serotonergic system exists, but that provides another line of kind of evidence regarding how antidepressants work is that they are reducing the severity of the neurotic traits that people have, which confers both acute as well as chronic maintenance benefits.
Okay, I'm looking at this study, and
Hmm.
I'm really a fan of the big five, and I've done an episode on neuroticism, conscientiousness, and extroversion. And I run most of my patients on
Hmm.
a neuroticism scale, actually, because I think it's very helpful. And actually, I've learned as well. I'm going to do an update on the big five. You can look at the subdomains of neuroticism,
Hmm.
and in someone who's, for example, narcissistic, they'll be higher in anger, but
Hmm.
all the other neuroticism domains will be average. There's
Hmm.
no linked to narcissism. Whereas, for example, in BPD, all of them will be fairly elevated, all the neuroticism subdomains. So I think neuroticism is kind of a blanket uh, that they may fall into a personality disorder, but
Hmm.
not necessarily. But we don't know what personality disorder they'll fall into because a lot of them are going to be high in neuroticism. Um, in this particular study, they compared the paroxetine versus placebo. And for the neuroticism, the effect size was 0.57. And with extroversion, it was 0.63. So these are big shifts.
Yeah.
And I think what your point is, and I think I want to get back to your point for this particular episode, is that it's not just depression that an SSRI is treating.
Hmm.
And further, um, it's not just blunting the mood,
Yeah.
as some critics of SSRI
Yeah.
say, like all this is doing is blunting your mood, because otherwise you wouldn't have this shift with neuroticism.
Yeah.
Um, and let me just say also, from my experience of treating patients over time, I've seen personality change. So someone may be born more neurotic, right? And someone may have gone through different traumas. We know trauma increases neuroticism, genetics change it. So it's like everything, right?
Hmm.
Therapy can improve neuroticism as well.
Yeah.
Interestingly, in this study, they compared uh, cognitive behavioral therapy with neuroticism as well. And let's see, paroxetine versus cognitive therapy. And the effect size was pretty small, and the p
Hmm.
value was not statistically significant.
Yeah.
So they both improved neuroticism and extroversion.
Yeah.
So that's cool.
Yeah, I agree. I think therapy is a big kind of factor as well. And my own kind of clinical impression working with patients is that the people who seem to do best on chronic maintenance antidepressant therapy tend to be the ones who get the most positive effects on their neurotic kind of traits. So people who are high on neuroticism and they take an antidepressant and their neurotic kind of traits go down, neurotic severity goes down, they tend to be the one that seem to prefer continuing on an antidepressant on an ongoing basis and seem to show the most outcome. And they also tend to be the ones where we see depression and anxiety kind of mixed in rather than, depression being just kind of a pure syndrome by itself.
Right. There's a subdomain in neuroticism of depression. But there are also subdomains of self-consciousness, like how critical do you view yourself? How emotionally reactive are you in anger? How impulsive are you? These are all subdomains of neuroticism. And so, yeah. Okay. I want to get through this though. Let's
Yeah.
go. So the controversy of the efficacy of antidepressants. Shall we jump to that?
Yes, yeah. And hopefully, I think at this point, I think a lot of especially I think psychiatrists involved would be familiar with the broad details of the controversy around efficacy. But it comes down to the magnitude of the difference between antidepressant response and placebo response in kind of randomized controlled trials, especially randomized controlled trials that have been submitted to the FDA for medication approvals. Now, the one of the largest meta-analysis ever done in medicine has been for antidepressants and included 522 clinical trials, 116,000 subjects, and it clearly shows that antidepressants separate from placebo with regards to kind of antidepressant response. And if you look at odds ratios of response, it kind of varies from a little above 2 for amitriptyline to 1.37 for reboxetine. But if you look at the actual magnitude improvement, like what is the change on the Hamilton Depression Rating Scale, that's a relatively small one. It's a 2-point difference on average between antidepressants and placebo, and it converts into an effect size of zero point 0.3, generally considered small. And this was kind of reaffirmed in a 2022 kind of meta-analysis of the FDA database, which again showed that in the placebo group, the average Hamilton Depression Rating Scale kind of score improved by 8 points, versus in the antidepressant group, it improved by about 10 points. So again, a kind of 2-point difference. So critics have been saying, well, like this, the scale is so big, it ranges from 0 to 52. What does a 2-point change matter? It's clearly clinically insignificant, and we cannot say on this basis that antidepressants have any kind of meaningful effects. And I think there are
And
three.
and
Yeah,
and to which I would say,
yeah,
yeah, this is a little bit depressing.
yes, yeah, and it's yeah. So yeah, so that is why I think the debate
Like,
has been so contentious. Like, what? Just a 2-point difference on Hamilton depression? How
uh,
can that be?
2 points is like, oh,
Yeah,
come on, like
yeah,
really? But
yeah,
the placebo is I mean, what this
yeah.
also says to me is placebos are very powerful.
There, yeah,
Um, but 2 points is not a huge difference in 52 points. So
yeah,
we're going to go through what this
yeah,
might mean rather quickly because we're trying to wrap it
yeah,
up here.
yeah.
Um,
Yeah, I'll be quick about that. So I think the first response kind of emphasizes the heterogeneity of the response patterns, that people don't respond uniformly, rather that some people seem to respond very well. They can experience large reductions in kind of depression or kind of severity. There are others who kind of show like a medium kind of response, and then there are others who show very little. So in the FDA analysis, when they kind of broke it down, they compared it in terms of people having kind of a trajectory of a large response, kind of, around 16 point, change in Hamilton, kind of having a more non-specific kind of response around 9 points, and then minimal response around kind of 2 points from baseline. And what they found was that in the placebo group, 10% of people had a large response. So a response that would be characterized as being, on the large directly, versus 25% of people in the antidepressant group had a large response. So
Hmm.
that's a pretty kind of, substantial difference. 25% large response in, antidepressants, 10% in placebo, and people who show a minimal response, was that percentage was lower in the antidepressant group. So 22% of people on placebo had a minimal response versus 12% on antidepressant had a minimal response. So what we are seeing is this shift, so that a lot of people are going to have, kind of like, medium-ish kind of response, but a subgroup, about 25% of people, are going to have a robust improvement that's going to show up. And when we look at just the average, that the average hides that heterogeneity, because it kind of collapses this variation into this average difference. And if you look at the number needed to treat for a large response for antidepressants, that's 6.7, which is, not super great, but a respectable number needed to treat when we consider overall medicine. Um, so that's kind of, that's one. So, the heterogeneity of response pattern is one strategy to it. The second response, kind of has focused on Hamilton Depression Rating Scale as an instrument itself. People have said that a total score on Hamilton Depression Rating Scale is really not the best way of looking at, how people improve. This is because the kind of questionnaire kind of rating scale includes, it's an idiosyncratic mix of many different items, and the weightage of, of items being devoted to different aspects is a little asymmetrical too. So for example, there's just one item about depressed mood, but three items about insomnia, and then all items, items are given equal weight. And also there are many items related to sexual symptoms and gastrointestinal symptoms, which in fact is concerning, because these are things that are side effects of antidepressants, because antidepressants worsen gastrointestinal functioning and sexual functioning. So the if we are looking at just the total score of Hamilton Depression Rating Scale, it's not giving us a fair idea of what's happening with
Hmm.
depression. So in a 2016 paper by Hieronymus and colleagues, they actually broke it down based on items of Hamilton Depression Rating Scale, and they showed that if you focus on the core symptoms of depression, if you focus on the core six items, you get a very consistent separation from placebo based on those. And if, for example, if you look at just the depressed mood item, the kind of effect size separation of that from placebo is 0.27, for the total score, but for just the depressed mood item, it is
Hmm.
0.4.
I think that's
So,
worth repeating. So it's higher
yeah,
effect size for when you look at specifically the
yeah,
depression scores. And for my clinical patients, I want to get them out of depression. And then, yeah, they're going to have some side effects. We're going to have to deal with that. But when they're not lying in bed all day, it's easier for them to exercise. It's easier for them to do lifestyle stuff. It's easier for them to go to therapy. So sometimes you have to get them a little bit less depressed so they'll
yeah.
actually seek treatment.
Yeah. So the core symptoms of depression improve more robustly compared to the Hamilton total score. And then the final kind of, strategy that people have used, in response is that, it's somewhat counterintuitive, but a 2 point difference from placebo is not the same as a 2 point difference from baseline. And so the a 2 point difference, every 2 point average difference from placebo can still be meaningful. And the way to appreciate that is by comparing this effect size by, with psychotherapy and other medical treatment. So if you look at comparisons of, antidepressants versus psychotherapy, but also kind of psychotherapy versus placebo, uh, psychotherapies, especially kind of, short-term manualized therapies that have been studied in research settings, they have the same effect size, average effect size, and antidepressant. So if if one says that, oh, a 2 point difference is not significant at all, one would be forced to say that, oh, then psychotherapies don't have a meaningful effect either.
Right.
And if you look at, general medical treatments, which kind of Stefan Lucht and others did in a paper in 2012, they actually showed that an effect size of zero point 0.3 is actually fairly kind of common and standard in general general physical health treatments too. And many accepted treatments have effect sizes of zero point 0.3 or lower. So in comparison to treatments in general medicine too, antidepressants don't fare that poorly.
Yeah, and I would say if the psychotherapy people were listening to this, were like, they would probably say something like, well, it's not the best way to measure it. The
Yeah,
best way to measure it is more like the OQ45, which you're going
yeah,
to see about a zero point 0.8 difference per session in someone with high reflective function. If you're a therapist, it's more like 1.2 or 1.3 per session. And you're going to say, well, you're going to, a year of therapy will get 75% in remission, right? Probably, right?
yeah,
I mean, that's
yeah,
like what they would say. And what I would say as a psychiatrist, if I was just doing medication, which I'm not just doing, but if I was just doing medication, I would say, well, this is the first session. If we get a little bit better in the first session, some people are going to respond, some people aren't going to respond. If they don't respond, we switch up the strategy until we find something that helps them respond.
yeah,
And so we're not just going to leave them with 2 point decrease.
yeah.
And it's not just going to be a 2 point decrease because there is a placebo response. Um,
Yes,
that's
and
significant.
right. This is over and above placebo, and there's a very interesting discussion in the literature on whether it is meaningful to subtract placebo response from an antidepressant response in this manner because. From what we know, it is unlikely that an antidepressant response and placebo response are additive. It's not like, you can add them together and get double the response. So, for example, think of, if you combine antidepressants and psychotherapy, you don't get double the response. You get a slightly more response because antidepressants and psychotherapy are not additive. You can't their response is not summative. In a similar kind of way, antidepressant and placebo response are probably overlapping. So, when we subtract the placebo response from the total antidepressant response, we're probably underestimating the
Mhm.
magnitude of benefit that is being attributed to antidepressants.
Right. And one thing I would say to support that is there's a study on placebo for Parkinson's, and they
Okay.
showed that the placebo actually increased the dopamine in the brain, which is what
Yeah.
we're targeting with
Yeah.
Parkinson's medication. So it's possible that just by taking a medication for depression, you're starting to target those areas in the brain where they're depressed, just like a placebo for Parkinson's targets the area in the brain for Parkinson's.
Yeah.
And also, there's spontaneous remissions, and there's the therapeutic alliance and the
Yeah.
connectedness of having a professional, and the therapy that goes on even in short visits. So there's all that happening, which
Yeah,
complicates it.
I agree. And clinical trials in many ways are designed to amplify placebo responses because it involves very frequent monitoring, frequent assessment, sometimes financial compensation. And so there's this kind of built-in incentive that kind of, there's an incentive to kind of boost the baseline depression responses to get people into trial, make them eligible. And then, because of all the support and financial compensation, the responses often kind of, the depression scores often decrease pretty prominently. So the RCT setup does not represent the kind of usual clinical treatment setting in that respect.
Avas Atab, this is amazing. You're an amazing psychiatrist. I was totally enthralled by reading this. This is top shelf.
Yeah, thank you.
Not to say you're an alcoholic beverage, but
Yeah,
top shelf information here. Um, it's truly articulate, and I hope you guys listen to or I hope you jump on the website, read his article on this, and also check him out on X, his Substack, and I will link those in the article and in the show notes. What's the best place to reach out to you if people are curious, have questions? Is it your X account, would you say, or
yeah, I would say I think X and Substack and Blue Sky are good places.
awesome? Thank you so much for coming on. I have to wrap it up to get to my next appointment, but
Yeah,
it's a pleasure, and I will definitely want to have you back on to continue the
yeah.
philosophy of psychiatry and the critiques on psychiatry and your perspective. So thank you.
I'd be delighted to. Thank you.